So let's kick off our first session entitled Beyond the Surface, Removal Strategies for Infection Control in Acute Care. This session will dive deep into practical, science-based cleaning strategies that go beyond surface-level cleaning to ensure better infection control in critical environments. I'm excited to introduce our speakers today. To my left is Darrell Hicks, the author of Infection Prevention for Dummies and a nationally recognized expert in environmental cleaning and infection control. Then we have Dr. Keri Lestage, founder of Clean Ops Collective, a leading voice on healthcare surface challenges and innovations. And over on the end here is Dr. Mark Weinsack, principal microbiologist at Contec, Inc., who specializes in contamination control solutions. Welcome to all of you. We're so glad that you are here.
Good to be here.
Yeah, so we're going to go ahead and dive right in and kind of just address the first thing we're going to talk about, the role that surfaces play in HAIs, hospital-associated infections, especially when it comes to patient rooms. So whoever wants to jump in first is fine, but what roles do surfaces play in HAIs?
I think it really was brought to light when we found out that with this antibiotic-resistant microorganisms that patients admitted to a room, if they had C. diff or MRSA, so some of these things that lingered after the room was cleaned that made the next patient in that room, even though it was terminally clean, made them susceptible by 60 to 70%. I've heard as high as 200% more likely to get the same bug that the previous patient had. So I think that's where we really got focused on. Surfaces are not non-critical, right?
That's exactly right. That's exactly right.
These surfaces are not non-critical.
Absolutely. Go ahead.
Yeah, I agree. And I think we'll probably get into this a little bit later, but, we talk about Spalding classifications, and this is what Darrell's alluding to, is that, Spalding classifications where you have critical, semi-critical, and non-critical, and a lot of the environmental surfaces and, in some cases shared medical devices are labeled as non-critical. And as Darrell sort of spoke about, there's been shown over and over again that they are indeed anything but non-critical.
Yeah, like we'll talk about a lot today, that the Spalding classifications still are referred to a lot by the CDC. A lot of the definitions that we talk about, a lot of the regulations that we're all held to, there's some room for improvement there in terms of making them more applicable to the world we live in today. I will say the Spalding classification originally was about medical devices, because we know transmission of microbes that cause infections has several different aspects to it. Hands being one of those, so we're not going to focus that much on the surfaces of the hands, but we know hand washing, hand sanitization is a critical part of reducing and breaking that chain of infection. But ultimately, folks are using devices, they are using surfaces, they are around surfaces that they're touching all the time. And so we know these animate surfaces definitely have a role in these microbes being transferred to ultimately getting inside of a patient. And so I think that's what we'll talk about. Hey, let's start with the patient. Where's the patient in a hospital spending most of their time? And then what do we start talking about how these surfaces are important as we move away from the patient?
Yeah. Let's talk a little bit about what some of those surfaces are. Specific to a patient room, what are going to be some of those surfaces that could be possible vehicles for pathogen transmission?
Well, we could start maybe with just the area around the patient, that 36-inch radius around. You can think about the tabletop that the patient is allowed to put their personal things or eat meals from. Obviously, the bed rails are big. The mattresses themselves that the patient is laying on, there's a lot of controversy and conversation around proper disinfection there. So I think just anywhere the patient spends the most amount of time clearly is a really important area.
Yeah, and I think you touched on one of the soft surfaces, that being the mattress, but that curtain that hangs 18 inches away from the bed that rarely gets changed and is contaminated, so it gets, pulled back and forth every time, they come into, especially if it's a semi-private room, that, between the two beds, their doctors and technicians are always pulling the curtain. And, many hospitals have, when visibly soiled, will launder it or will change it. And so I think that that is a contaminated surface that is kind of flying under the radar. There's been numerous tests that say that, growth happens within 14 days after a clean curtain is hung. So the contamination is there, but I think it's one of those things that kind of flies under the radar.
And what type of pathogens are we talking about? What are some of the things that we're seeing HAI-wise that are being transmitted in hospitals? I know it kind of depends on the region and the hospital, but what are some of those common ones?
Well, each type of hospital-associated infection really has its own set of microbes that can cause that infection. So if we're talking about a urinary catheter and what's called CAUTI, that long acronym that means getting a urinary tract infection, but it's catheter associated. So again, these are microbes oftentimes that are associated with the patient's own body. And if the nurses are not careful in prepping that area when they're inserting a catheter, whether it's into the bloodstream or into the urethra, that's where these microbes that are on folks' skin or on gloves, or again, even environmental pathogens. So, it's the classic name. We could go through all the different acronyms, E. coli, and a whole list. I mean, if you want to impress people by showing all the Latin that we know, but then we all got all the acronyms, because most of these microbes have developed resistance to the common antibiotics. So the classic thing was, folks are going to get it, if you leave a catheter in for a certain amount of time, they're going to get an infection, but we can treat that infection with an antibiotic. Well, now we're getting multiple resistant microbes that are resistant to multiple antibiotics. And so now the idea is back to prevention. How do we keep these infections from occurring in the first place? But I think the one that's most associated with surfaces in hospitals, and the ones that really freaks people out, is C. diff. So Clostridoides difficile, again, microbiologists had to change the name again, but it's still C. diff. And this is a spore-forming bacteria that, again, very resistant to being killed by disinfectants, because essentially it's like a gobstopper. And it's got so many layers within the spore, but if it gets inside, if people ingest that spore, enough of them, they can actually start to grow in their intestines and cause this horrible disease. And so that's probably the one that folks get mostly freaked out about, because you can't necessarily say it's associated with a particular medical device.
Yeah, I think the other thing with C. diff that makes it tricky is that wouldn't be unlikely that one of us sitting here is colonized with C. diff. That it could be part of our natural flora and we would have no ill effects as a result. And it's only through the introduction of use of antibiotics that perfect balance that your body's trying to maintain gets off balance. And then all of a sudden you've got an organism that naturally lives there. All of a sudden you've got this overgrowth that is occurring that causes major problems.
And the major route of entry into the patient is fecal oral.
That's right.
And so this feces that winds up, I call it the fecal patina, and it doesn't happen just in the restroom. I believe that we have this fecal patina that winds up settling on those surfaces, and we don't engage the patient in cleaning their hands before they do their meals, or if they're confined to the bed, then they've got a bedside commode sitting in that patient zone too.
That's right.
And that thing getting properly processed and everything, but there's opportunities, but it's still the way that it gets transferred is fecal oral.
Yeah.
Absolutely. Dr. Lestage, I know you spoke a little bit earlier about mobile devices. Tell us a little bit about some potential considerations there with those particular devices.
Yeah, absolutely. So there's a team out of Australia that just published, they called it the Clean study. Just an outstanding piece of work. So what they ended up doing, they were able to show, is that they had a dedicated team of professionals that were responsible for cleaning mobile medical devices, and they had, to the tune of about 3 hours a week, was dedicated specifically for this route. And what they found is that through having a dedicated team that was trained and repeatedly trained on a regular basis, the levels of HAI reduction in that hospital was really significant. And so all of a sudden you get this understanding, and you've got real hard data that shows that transmission is in fact happening through these devices, and that having a dedicated trained team to look after it really makes a giant impact in the outcomes of your patients.
It sounds like education, training is kind of a key component of infection prevention or control.
Definitely.
Well, let's transition into some of the cleaning and disinfection aspect of, in the patient room. We're going to use a lot of jargon today, so let's start with some definitions. Who creates these definitions, and why are they all not the same? Terms like cleaning, sanitizing, disinfection, sterilization, bioburdens, that sort of thing. Give us some help in understanding what those definitions mean.
Well, I'm going to start with an organization that involved with the products, but not necessarily the process. And what we've seen is a disconnect in many times of what the Environmental Protection Agency that regulates disinfectants, they don't regulate cleaners. They only regulate things that kill or mitigate or have some effect on the health of microbes. Okay, basically these products are pesticides, and the pest is the microbe in this case. And so they have very strict definitions of what can be labeled as a disinfectant. And anything that's not a disinfectant or a sanitizer, which has a lower level of kill, is essentially up to the market to decide, well, does this have any benefit in terms as a cleaner? Cleaner is considered more of an aesthetics. So cleaning, in the words of what the CDC says, is really just removing things from a surface. Okay, so not killing, but just removing. Now, some of those things are going to be dirt and dust, and even microbes that are attached to that dirt and dust, and that's okay. But as soon as I talk about killing those microbes, now that becomes a disinfectant or a sanitizer or a sterilant. Really, I think what we're focused on in the environmental surfaces and what we do with normal, in most cases with patients on these surfaces, is disinfection. And like I said, well, what is disinfection? Well, the CDC just says you're killing everything except bacterial spores, and now if you're using a sporicidal disinfectant, that is a sporicidal disinfection. But within all that, it's like, well, what am I really killing? Does it always work that way? What is this wet contact time? What is all the details within that disinfection process? And again, so the EPA says we have these methods for measuring this in the laboratory, but it's up to the users to actually implement this in a way that's going to have a beneficial effect in reducing the risk of HAIs.
And just to make it a little bit more complicated, so then we've got this reference to low level, intermediate level, high level disinfection, which I really dislike. I really much prefer talking about a sanitizer or a disinfectant or a sterilant, because the way that I think about those terms is that there is a very real association with the type of organism that it would kill. So a sanitizer, we're talking about bacteria only. Generally speaking, we're talking about a specific efficacy level of about 3 log. And similarly, as you go up the chain, however, when you talk about low-level disinfectants, they talk about vegetative bacteria. Intermediate disinfectants, they pull in things like fungi and TB and those areas. And then you get high-level disinfectants. Sometimes they do a little bit of spores, but not very many, and the definition gets a little squishy. So I'm actually a much bigger fan of using, the EPA definitions as opposed to the CDC's.
Absolutely. There appears to be some distinct differences between cleaning versus killing, yet the EPA says one-step disinfectant can clean and disinfect at once. Why?
I think that we, too often, we interchange those terms all the time. Cleaning, disinfecting. People will call cleaning because it involves disinfecting. Even labels, not labels, but advertising. It talks about 99.9%. Well, of which bugs, but flu season's around, and so people are buying these for home and saying, well, it kills 99.9%. That's good, right? Close is no cigar. We've left much more on the surface after doing that. So I think that we need to get rid of the term clean, because clean can be a noun, it can be a verb. But clean, because people, if you ask them, how do you clean this room? And they talk about the steps that they do, not that they are removing soil. And I believe that if we do a good job of removing soil, that gets to the CDC's definition of clean is removing the majority of the soil from a surface, and with the soil goes the bad guys. And so you're removing the food from the bacteria. Bacteria need food to survive. So if we can remove the soil, then do a better job of soil removal, then the disinfectant works. And their CDC's definition of disinfectant is that on pre-clean surfaces, that the disinfectant will kill the surviving microbes on the surface. So it's really a two-step process: clean, then disinfect. And I think that the one-step disinfectants still should, if they have that, then it should be one step that can be used to pre-clean, and then the next step, using the same product, you can disinfect. But I think that the goal is to leave the room in a better condition than when you came in.
Hopefully.
And if we don't do that, and that it is not a threat to the patients or to anyone that comes into that room, that's the goal. We'll never get to disinfectant, totally disinfected room. You work with clean rooms, Mark, and that's a different standard, way higher level. But as long as we have sick patients who are, their own body flora is shedding these organisms, it's never going to be disinfected. You just take a snapshot of time, and for that snapshot, it's disinfected. But from there on, it gets recontaminated very quickly.
Just to build on that again about the one-step disinfectant. So the way the EPA defines this is basically if a disinfectant can kill in the presence of light to moderate soiling. Okay, well, now we've got a very general term. What does that mean? Well, there's a method they run, and that method is using a little bit of cow serum. And when I say a little bit, very little bit. A little bit that you can't possibly see with the naked eye. And basically they say if the soiling is visible, you need to pre-clean, or you need to clean before you disinfect. And so the issue is when I go into a room to clean it, yes, there are some obvious examples of visible soiling, okay? But then there's a lot of examples. The microbes are so tiny, it only takes a few to cause infection, that to be able to walk into a room and see a spot of fecal material on a bed rail, underneath the bed rail, it's not going to happen. And so that's visible soiling. The EPA would say we need to pre-clean that, and say, well, I didn't see it. So I didn't see visible soil. I didn't see it. So it's kind of has led folks, I think, to take some shortcuts, and it does mean, again, the disinfectant's a little bit better than one that didn't pass that test, that couldn't even kill it passed the test method with some soiling. But it has kind of made folks think, if as long as I apply a disinfectant, I don't have to do this mechanical removal of the dirt and debris, which ultimately, like you said, provides the food there. I know one of our team members always says, reset the infection control clock. Let's talk about that versus what level did we, how many nines did we get from our treatment?
But we rarely talk about soil removal as opposed to what gets left. We talk about soil removal as though this cloth used this way with this product gets us soil removed, but the soil that remains is where what is left is where the disinfectant then kicks butt, right?
Mm-hmm.
Let's talk a little bit about some of those soft surfaces. The Joint Commission and other entities require use of EPA-registered disinfectants in healthcare facilities. These are only approved for hard and non-porous surfaces. So are these the only surface concern? How do we reduce the risk on those soft surfaces?
It's an incredibly difficult challenge. So in the case of mattresses, first of all, they're highly contaminated. And in order for those materials to work properly, they need to be breathable in order to, keep the patient comfortable, which is another kind of issue, is that you can't make a hard surface out of a mattress. Mm-hmm. EPA regulations basically say that you can't disinfect a porous surface. You can only sanitize a porous surface. So all of these elements really contribute to the fact that mattresses really harbor a lot of pathogens, and that if you go online and even just Google disinfecting of mattresses and all the images of broken, cracked, damaged materials, again, it becomes now not just a potential problem. It becomes a reservoir for these microbes to be able to thrive and continue. And as Darrell had mentioned before about this idea of patients who are now going into rooms that have supposedly been terminally cleaned, but because there's been a patient that were on contact precautions, for example, now all of a sudden you've got that same mattress that is now fully contaminated still with those organisms, and that's why we're seeing that re-inoculation of those patients.
Yeah, because when we talk about C. diff has a lot of diarrhea. The patient has a lot of diarrhea. Mm-hmm. And it's mostly on that bed.
That's right.
And so even cleaning the patient up, having a chuck under them and all that, those spores are spread on that mattress. And now you cannot disinfect.
That's right.
I think that the best you can do would be probably 80% of soil removal, but I think that what we know about those mattresses is that they can retain fluids.
Yes.
If you've ever unzipped a mattress cover, and Joint Commission's got a standard about examining these mattresses on beds. FDA has got, I refer people to the FDA way of doing things because those mattresses are a Class 2 medical device, and they have to be processed a certain way. And the FDA has got the steps is that you use a neutral cleaner, you clean the mattress, and then you rinse that, and then you apply your disinfectant and let it dwell time. And then after the dwell time is up, then you have to rinse it again and dry it, and then make the patient bed. Well, that adds so many steps that terminal clean now is probably 10 to 15 minutes longer.
That's right.
And so hospitals don't want to do that, but that is the FDA's advice, since it, Mark, you talked about these different agencies having, overlapping, and they don't necessarily agree with each other, but the EPA will say, well, that's for a hard non-porous surface. And so to a hospital housekeeping department, that's the only one we got, So you're using it in a manner that it was never intended for.
That's right.
Well, it was never intended because they don't have a way of testing it.
Right.
So that's where the EPA just says we've got to have one test method that works for all chemistries, so we can allow people to register these products, have some bar that people have to pass, and they've struggled with what would be a representative. They use like stainless steel or glass or other hard surfaces as the surrogate for all other materials. But they haven't come up with what could be a surrogate for a mattress. And now it's, again, the idea that, people should be applying these chemistries and following some kind of procedure to clean and apply a germ-killing chemistry to mattresses. Okay, you shouldn't just say, well, it's not approved for that, we're not going to do it. And I'm not aware the Joint Commission would say you can't use that on there. Just maybe don't use the word disinfect. But you need to treat these soft surfaces as much as you can, particularly the mattress that are in such intimate contact with the patient. But then we get into what we'll talk about in a minute, material compatibility.
Yes.
Why are those mattresses all ripped and torn and faded?
That's right.
And this gets into, again, the compatibility of the chemistries we use with these different surfaces.
Agreed.
I think that's an excellent segue. So let's jump into the material compatibility. Give us sort of an overview of what we need to be considering when we consider material compatibility.
Well, we're not going to offer as many solutions as folks might like of, hey, they cleared all this up for me. We're just going to maybe elucidate the issue and why do we have a problem? So we have disinfectant manufacturers that can do certain tests, and all of them do. We'll have a material compatibility chart that explains, here's the materials we've exposed our disinfectant to for a certain period of time. This is the ones we saw some deterioration. These are the ones we didn't. Okay, but now you have the people that make all the equipment, the surfaces, the devices that go into a hospital. And they're saying, oh, there is no way we could test every single disinfectant for its impact on our product. And they can't just say, well, I tested bleach, so all bleaches are fine. Or I tested quats, again, as Keri has told us, there's a lot of different formulation differences that can impact the susceptibility to these products. So you've got this disconnect between the manufacturers and the people that make the chemistries. And then you've got the user stuck in the middle, reading IFUs that says only clean this mattress with soap and water. Well, that's not going to cause any kind of kill. Okay, so what do I do here? So that's the way to elucidate the problem, but trying to come up with a solution. Again, there are certainly opportunities to have better collaboration between those entities for people to understand. But the users, the people that purchase these products, also have a role in this. Because the manufacturers say, I can make this medical device, this anesthesia cart, this blood pressure cuff, this mattress, I can make it more resistant to disinfectants. It's going to cost more. So is somebody willing to actually pay to have a product that can handle this robust disinfection for the lifetime of the article?
Yeah.
Yeah, I think the other piece of it too is the regulatory environment that we're in. Disinfectant manufacturers are required to hit a very specific bar, and in order to do that, the type of chemistries, the suite of chemistries that we've got available is pretty limited, honestly. And when we look at one of the things that I kind of rail against a little is that we've got organizations out in the industry that are bringing really innovative, really interesting technologies to the table, but the regulatory environment is such where there isn't specific protocols that talk or can address this new way of applying these technologies. And so if there isn't a protocol that they can test against, then there is no regulatory pathway, and then they can bring it to market. So I think it's a bit of this constant catch-22 where we've got the regulatory environment, you've got the manufacturers of the equipment and the manufacturers of the products themselves, and as you pointed out perfectly, you got the patient sitting in the middle.
Well, on July 1st of this year, the Joint Commission kicked off their new EC environmental control standards, and they got rid of about 70% of their previous EPs, evidence of performance, and so they've dwindled it down, but we started talking about that near patient environment. And so what the CDC is recommending is that if it can't be disinfected, then we need to use a disposable one. So that if you can't disinfect it, then the pathogens have got to go. And there is a company that Keri is familiar with, but they make they call it a mattress protector. But anyway, this mattress cover goes over and can be laundered for up to 400 launderings. And so what you do is you discharge that C. diff with the patient.
That's right.
It goes to the laundry, and it comes back, and it's at the laundry. It gets shrink wrapped individually, And so it stays sterile, if you want to call it that, until it's ready to go on the bed. But so that solves that, and then the one for the other soft surface, which would be the curtains, but to go to disposable single-use curtains. And that during COVID, we did a lot of curtain exchanges, and people got caught up in they didn't have enough cloth curtains, blah blah blah. But what they did was they went to get a disposable curtain that was recyclable. Well, none of them were recycled. They all went to the landfill. So we have this sustainability with the disposable single-use items, but I think if you can validate that it's going to improve that near-patient environment, then you ought to do it.
But part of that improving that environment is kind of that education piece you guys were talking about. Let's talk a little bit about the product versus the process. How important those two things are and how they work together. I know that we've got instances like how to apply something versus frequency of application. Let's dive a little bit into the products and the process. So what is that role? What is the role of process, product, and person in cleaning a patient room?
That's a three-legged stool.
It is. It is.
If one of those doesn't work right, then the stool doesn't stand. So it's all three.
But I would argue that we probably rely too heavily on the product.
Yeah.
And I think we need to spend more time on the process and the education and, for the folks that are actually doing the cleaning to be able to not only make sure they understand the why behind what they're doing, but to elevate that profession to the level of importance that the role that they're playing actually delivers. So I think those are two legs of the stool that are a little too short for what we've got.
Giving it a little wobble.
Yeah, that's exactly right. That's exactly right.
Yeah.
I mean, again, no product can solve all the issues if it's not used correctly. I think, again, products that focus on ergonomics, on making the job easier, helps inspire some of the folks that are doing this cleaning to appreciate that they're using clean tools to create a clean environment, and folks are trying to invest in things that are lightweight, things that reduce, again, injuries from all this cleaning and the stress that goes on with that, to ultimately combat the fact that just want to say, turn this room around faster. And make sure you don't miss any spots. And all the things that we say are kind of counter to, well, how do I do that when these are the tools that you're giving me? So I back to the point kind of just about, mentioned about sustainability, again, that is a major initiative with a lot of hospitals around the world. It kind of took a step back when we went through the pandemic. We're more about human sustainability. But certainly it's not something that we're ignoring there. But I would say, again, if people can properly process objects like cubicle curtains, like towels, like sheets, like microfiber mops, if they can go through the right process to remove those microbes or use a sanitizer to get rid of them, then that looks like that is a way to go. The problem with a lot of that is it's just really hard to do, particularly with microfiber. Really hard to clean something that was designed to be able to pick up and hold. Right. Mattresses are meant to be breathable, but they're meant to not hold things if they're not damaged. And microfiber is just the opposite. So that's where you've got to decide, when does it make more sense that it's just easier to dispose of something, and then look at what is the environmental impact of disposing of that versus the actual energy and water that's used to reprocess. There are some parts of the country and the world where water has become more of a critical resource than the energy.
Exactly right.
And so that's where all these things got to be balanced, and that's where folks can do life cycle analysis and kind of compare these things. But again, back to the people that are doing this, very much underappreciated, or they a lot of times don't feel like they get enough cred for being the ones to implement all these policies that come from the CDC and infection control and the EPA and the Joint Commission and all these folks sit in their offices and kind of come up with these rules, which are based on good science in many cases, somewhat outdated in some cases, but good intentions. But then how do we roll that out to the folks that are actually implementing that to come up with a practical way of creating a safer environment?
It's a really good point. A lot of times in hospitals, there's the infection preventionists and then the EVS teams providing that the cleaning involved. And so having that bridge of communication between those two departments is absolutely essential.
I think one remaining thing about the three-legged stool, product, process, and people, is that we have to be able to measure whether it works.
Agreed.
Yeah. So the product's got to work, and once you validate that, we can do it with ATP, we can do it with fluorescent markers, but the one that I think that we need to pay more attention to is supervision. I know that housekeeping departments, EVS departments, that one supervisor may have 25 people.
That's right.
To ride herd on today. That's near impossible when they're spread over 10 acres. If you're standing in the kitchen, you can watch 10 people doing their jobs, but when you've got to go all over the hospital. So I think that we need to increase the supervision and have eyeballs, because, the thing is that we can train them, we can educate them and train them, but whenever I walk by and see the guy that just cleaned the toilet, I watch him clean the toilet in this hallway bathroom, and then he goes over and starts wiping down the sink. And so, talking about cross-transmission, I stopped him and corrected him, coached him. But, if we don't go out there and watch what is actually happening, then we don't know that these policies and processes are actually being followed.
That's true.
How do we gauge some of that, sort of those metrics for success and failure when it comes to infection prevention? What are some of the ways that we can tell what we're doing is making a difference?
I think HAI rates that's the big one. That's the big one. And I think, we've had, and as part of the Clean study, one of the things I thought was interesting is that, the first question is how am I ever going to afford 3 hours a week of a dedicated team? And what they did is when they actually looked at the analysis of the difference in cost, because this reduction in HAI has prevented significant amount of cost for the hospital. The cost differential between applying these teams versus the avoided cost was, you would want half a dozen of these teams around the hospital given that cost differential, because it was so cost effective to do so. So I think we can't be so myopic that we're just looking at specifically at labor cost or product cost. I think it's a much more holistic picture of what are the balance and trade-offs that you're making.
What is the cost of patient safety,
That's
really?
exactly right.
Yeah.
That's exactly right.
Yeah, and we never lose sight of who it is that we are trying to prevent from getting an infection. And I think it's much worse than what we're being told by the statistics. And I think that these are preventable infections if the right process, products, people was there. I think that many of these are preventable infections, and it changes lives. I mean, whenever I wrote the book, Infection Prevention for Dummies, my daughter-in-law at the time was 37, working out in the facility because she was running marathons, doing training, had personal trainer, and so she got an infection, this part of her hand, from weightlifting, I guess. And turned out to be MRSA, and within 8 weeks she was dead. No. And it changed our life, our family, forever. And they said it became a bloodstream infection, and she's 37, very healthy, but you can tell that story millions of times over. And but we have an opportunity in hospitals to first do no harm.
Agreed.
Well said. Thank you so much for joining us on this panel. With that, we'll conclude up this particular session. For those of you tuning in at home, if you have a question that pops up in your mind, feel free to ask it throughout our entire webinar session. Again, very helpful insights. Thank you all for being here and giving us your knowledge, your expertise, and especially that heartwarming story. That was it's important to remember the why behind infection prevention. It's real people, real patients.